In this discussion, we're going to be looking at hypercalcemia and the management thereof, specifically in the acute care setting. Let's start out by initiating a case presentation, which we'll subsequently finish in the second module of this. This was a 56-year-old male who was admitted initially to the medicine team several years ago with lethargy and confusion. His past medical history at that time was significant for hypertension, as well as coronary artery disease with a past MI. As a result of that, he had ischemic cardiomyopathy with an ejection fraction of 35%. He also had a fairly recent pulmonary embolus for which he was on anticoagulation. He also had Lynch syndrome, which had been documented with 2 prior colon cancers, requiring a right colectomy in 1994, and more recently, actually earlier in the year, at the time of the patient's subsequent presentation, a sigmoid colectomy for which or a sigmoid colon cancer for which he underwent a low anterior resection earlier in the year of his presentation with this issue. Past procedural histories: cardiac catheterization with drug-eluting stents in 2019. He had undergone uncomplicated left inguinal hernia repair in the 1990s, as well as an ankle fracture fixation. Again, right colectomy in 94 and a low anterior resection in October of 2022, so just about a month or so prior to his presentation with the lethargy. At the time of his initial physical exam in the emergency department, he was noted by the team evaluating him at that time to be disheveled. He had dry mucous membranes. He was having a lot of diarrhea, liquid bowel movements pretty much on an hourly basis. Initial labs: basic metabolic panel, not maybe as bad as I would have expected given the amount of diarrhea that he had. Does look a little bit on the dehydrated side with the BUN and creatinine, which are elevated slightly above baseline. Magnesium and phosphorus levels, which are on the low side, but most significantly, a very high calcium level at greater than 18. After that initial result was obtained, a PTH level was subsequently obtained, which was also elevated at 293. As the team that was admitting him at that time looked back at his history, they did note that he had previously recognized hypercalcemia. In March of that year, a calcium level of 12 had been obtained, and a PTH, while not as high, was still inappropriately high at that time at 77. He subsequently underwent a sestamibi scan, which was reportedly negative, and then the ball was kind of dropped after that. And I think this highlights one of the perils of obtaining localizing studies for the purposes of diagnosis. Sestamibi scans, ultrasound, those are to help with localization, as we'll talk about later on, of parathyroid adenomas when they're present. They are not diagnostic studies. The diagnosis is made clinically and on the basis of lab values when you're talking about hyperparathyroidism and other causes of hypercalcemia. So kind of a frequently repeated mistake that we see in practice where patients' calcium's high, sestamibi scans obtained, they don't see anything necessarily, and they say, well, okay, they don't have hyperparathyroidism, which is not the way, or not the utilization or an appropriate utilization of the sestamibi scan. The patient was therefore subsequently lost to follow-up. Interestingly, 7 months later, when he did undergo his low anterior resection, he was observed to have a slightly elevated calcium level at that time. He had issues with severe diarrhea after his low anterior resection, which isn't too terribly uncommon, but had probably been not adequately addressed by the operating team, frankly. And that was felt initially to contribute at least somewhat to his initial presentation. So we ultimately see this patient in consultation, but I'll just kind of leave the case study there, just kind of to whet your appetite. And let's start out and look, though, at some of the basic science behind hypercalcemia management and management specifically of hyperparathyroidism. Because in order to appropriately understand the pathophysiology occurring in a case like this, it's really necessary to be familiar with the basics of calcium regulation. The chief cells of the parathyroid gland express calcium sensing receptors, which facilitate detection of even minor changes, minor fluctuations in the serum ionized calcium concentration. such that if your calcium level drops, there's changes which occur in at the calcium sensing receptor level, which results in an increase in parathyroid hormone release. With an increase in the parathyroid hormone release from the chief cells, you have bone, gut, and kidney basically being stimulated to release calcium or to pull calcium back into the body, ultimately to get more calcium in the bloodstream. The way this occurs specifically at the level of the bone, you have stimulation of bone osteoclast, which within minutes leads to a bump in the calcium level or an increase in the calcium coming from the bone into the serum. In similar fashion, renal calcium reabsorption is accentuated or stimulated by PTH, and within minutes, you're reabsorbing more calcium than you were before the PTH stimulation. A little bit longer acting, but also important and very durable in the longer run, is vitamin D3 activation, which leads to increased intestinal calcium absorption, and this takes place more over days. So you have bone, gut, and kidney here, the bone and the kidney occurring within minutes of PTH stimulation to increase the amount of calcium being put into the serum or retained and brought into the serum, and also on a longer term basis, increased vitamin D3 activation leading to increased gut reabsorption of calcium. And abnormalities in any of these steps has the potential to lead to calcium imbalance. Now, in many instances, this just causes mild levels of hypercalcemia, and patients are therefore very often symptomatic, at least early in the course of this. It is, however, it has been found that even relatively mild levels of persistent hypercalcemia can be harmful, as they cause increased risk of osteopenia, increased risk of osteoporosis, and cardiac arrhythmias specifically when you're talking about hyperparathyroidism. There are the effects of having too much parathyroid hormone circulating around, and the resultant increased calcium can, even if the patient is otherwise asymptomatic, lead to a long-term increased risk in bone complications and cardiac arrhythmias. And that's why, as we'll see in a little bit, that even most cases of asymptomatic hyperparathyroidism are best operated on. Now, prior to the ability to routinely measure serum calcium levels, the diagnosis of hyperparathyroidism was much more difficult than it is today, and particularly it was hard to make the diagnosis in a timely fashion. So patients typically suffered years of excessive osteoclastic activity prior to being diagnosed, prior to presenting, and certainly prior to being diagnosed. Many therefore manifested as osteitis fibrosis cystica, also known as von Recklinghausen's bone disease. And these patients, due to the long-standing inappropriate amounts of hyperparathyroid or high amounts of parathyroid hormone, had significant bone breakdown with resultant bone pain and osteopenia, subperiosteal bone reabsorption, bone cysts, and in the skull, what's called so-called skull salt and peppering. And so back in the day, prior to ease of measuring serum calcium levels, 80% of patients who presented with hyperparathyroidism were diagnosed as a result of osteitis fibrosis cystica or similar dramatic presentations. In this day and age, it's 1 to 2%. So it's much less common that you see these dramatic bone depleting presentations of hyperparathyroidism. More from a historic interest than anything, but just in case, because you may see a case or two of this over your career. What does osteitis fibrosis cystica look like? It looks like patients that have, particularly in their distal phalanges, subperiosteal reabsorption of bone, as pictured here. Also bone cyst formation, as pictured here in these two radiographs. This very profound case demonstrates the severe brown tumors and bone cyst formation that can occur, and as you can see here, very dramatic bone destruction which has occurred over years of untreated hyperparathyroidism here in this case. Here's the salt and peppering of the skull that you see, and again another picture of the classic appearing subperiosteal reabsorption on the distal phalange. Again, though, these presentations are quite uncommon in this day and age. How do patients present in the modern era with hypercalcemia and hyperparathyroidism? Now, the classic memory key from medical school, at least back when I went to medical school, was stones, groans, and psychogenic overtones to help prompt some of these ways in which hypercalcemic and hyperparathyroid patients present. It affects the GI tract, and constipation, nausea, kind of non-specific abdominal pain. That's some of the groans that is talked about in the memory cue. So with persistent hypercalcemia, you get increased incidence of constipation, nausea, and just kind of a diffuse and non-specific abdominal pain in patients. These patients also have a risk of pancreatitis, which is increased from the baseline. So GI side effects or GI manifestations of persistent hypercalcemia, constipation, nausea, abdominal pain, and increased risk of pancreatitis. Neuropsychiatric manifestations, often kind of a little bit harder to put your finger on, but depression and kind of mood changes, lethargy if it gets bad enough. And so there's neuropsychiatric manifestations of persistent hypercalcemia as well. Renal manifestations, these patients are at increased risk of kidney stones. They're at increased risk of a condition called nephrocalcinosis, where you actually have calcium deposition within the kidney parenchyma, which is something that can lead to irreversible CKI. And when you'll see when patients present with acute hypercalcemia that to a significant degree, very frequently acute kidney injury will be part of that manifestation. But kidney stones, classic manifestation of hypercalcemia. I forgot to mention too, there's an additional stone, and that is increased risk of gallstones, which kind of goes along with the GI tract. But when you're talking about the stones, groans, and psychogenic overtones, the stones are gallstones and kidney stones. Or if the pancreatitis is severe enough, you might occasionally have pancreatic stones, but that'd be less common. But so it affects the GI system, it affects the neuropsychiatric system or the central nervous system in a neuropsychiatric fashion. It affects the kidneys. It also affects the musculoskeletal system. Again, not typically as dramatically as it was in the old days when the diagnosis was delayed, but patients will often present with some amount of osteopenia still, weakness, fatigue, muscle and bone pain. There also can be cardiovascular manifestations with QT alterations and occasionally significant cardiac arrhythmias. Also, these patients that have persistent hypercalcemia are at increased risk of hypertension. So this is how patients will typically present when they come into the office and are initially diagnosed by getting a calcium level which is high. Less commonly, patients will present acutely, and when they come into the hospital with acute, very high calcium levels, what we're going to call a hypercalcemic crisis, most often due to hyperparathyroid crisis, they will typically look significantly volume depleted, have significant secondary AKI and electrolyte derangements, and will very often be lethargic even to the point of optimization. What do you do with these patients when they present? These patients, specifically, I'm speaking now of the acute presentation of patients with hypercalcemic crisis, if you will, or acute hypercalcemia. And we're going to get to the workup that you would do on an outpatient setting, because that's the workup's going to be essentially the same that you would do on an outpatient setting that you will do on an inpatient setting. But the important thing to recognize when patients present acutely, such as would land them in the ICU, is that you really need to initiate treatment while you're doing the initial diagnosis, or they may get ill enough that they have bad complications and don't make it to the point you get to definitive diagnosis. So really three basic principles that go along with or that comprise the acute management of patients presenting with severe hypercalcemia. Volume depletion correction, so volume resuscitation, which is going to be with isotonic fluid, typically normal saline. Pharmacologic means to inhibit bone resorption and therefore decrease the acute increase in calcium in the bloodstream. And then defining and ultimately addressing and treating the underlying cause. And the aggressiveness and urgency of the treatment obviously depends upon the severity of symptoms with which the patient is presenting, as well as how high the calcium level is. Now, just talking about calcium levels, one thing we need to keep in mind is that if your patient is significantly hypoalbuminemic, you can underestimate the calcium level, and there is a correction factor for that we need to be reminded of in relation to total calcium, that if your albumin is significantly less than 4, you have to take that difference, multiply it by 0.8, and then add that number to the measured total calcium to get the true total calcium. In this day and age, most of us, rather than going through that rigmarole, will just get an ionized calcium. So an ionized calcium isn't thrown off by albumin, and that's probably the best thing to do is just check an ionized calcium. But if you're just working with total calciums only, recognize that the patient is hypoalbuminemic. You do need to account for that and correct for that. So when these patients come in, they need fluid resuscitation. Again, typically with normal saline, don't want to use lactated ringers because there's calcium in that. And this is aggressive fluid resuscitation, 2-liter bolus, and then you're running them at anywhere between 2 and 500 an hour, depending upon the patient's body size, what their heart's like, and other factors. Occasionally, Lasix can be helpful after the patient has been adequately volume resuscitated. You have to be careful with that, though, and we'll talk about that in just a minute. Patients with very high calciums, and I'm talking total calciums greater than 13, or patients, maybe their total calcium level is a little bit lower, but it's increasing rapidly, specifically by greater than 1 a day, and patients that have significant mental status changes just as a result of the hypercalcemia. These patients meet the criteria for a hypercalcemic crisis, and most commonly, it's due to parathyrotoxicosis, also known as hyperparathyroid crisis or parathyroid storm, where the etiology of that very high and sometimes acute onset of high calcium is an inappropriately elevated parathyroid hormone level. This isn't a real common manifestation of primary hyperparathyroidism. Only about 2 to 3% of patients that are hyperparathyroid will present with a parathyroid storm. But you need to recognize it when you see it and know how to treat it, because this is something that we can cure the patients from surgically. More often, patients will come in the office just with some more mild symptoms, and you'll do the workup there. But again, difference from when they present to the hospital, you've got to be treating them from the get-go while you're initiating the workup. So hyperparathyroid crisis or parathyroid storm or parathyrotoxicosis, whatever you want to call it, is the triad, if you will, of a markedly elevated calcium level with a significantly elevated PTH and significant symptoms requiring admission. And you can see here the manifestations of these very frequently. Again, GI manifestations, as we've talked about, CNS manifestations with significant alterations in mental status, very frequently acute kidney injury, musculoskeletal manifestations, very frequently, most commonly kind of non-specific in that symptomatology of weakness and fatigue, and cardiovascular manifestations can occasionally be seen. A recent article in the American Journal of Surgery was authored by authorities from Case Western or investigators from Case Western, and they compared specifically 18 parathyrotoxicosis cases or hyperparathyroid crisis patients here in the orange highlighted column here, and contrasted them with a much greater number, specifically 765 patients who just presented more in the outpatient setting with hyperparathyroidism. So this is contrasting kind of non-acute presentation of hyperparathyroidism with patients presenting in a hyperparathyroid crisis. And just looking at some of the differences, you can see significant differences statistically here in the extent of the PTH elevations. Not surprisingly, the patients in parathyroid crisis had much higher PTH levels. They also were noted to have significantly higher calcium levels, a mean of 15.7 versus 11.4. And they're also noted to have lower phosphorus levels and higher rates, interestingly, of double adenomas, or excuse me, not double adenomas, but higher rates of ectopic glands and malignant glands. So a much higher rate, interestingly, in this study at least, of ectopic parathyroid glands in patients that present with parathyrotoxicosis or hyperparathyroidism of an acute degree, and a higher incidence of parathyroid carcinoma, which is quite uncommon. It's not at all uncommon if you have the unusual entity of a parathyroid carcinoma that they'll actually present in a hyperparathyroid crisis. Also, you can see a mortality of a little bit more than 10% as contrasted with a 0% mortality in the patients who just presented with non-acute hyperparathyroidism. So it's certainly important as we look at these patients to recognize there's a number of things which can cause this. However, you're going to think when you see a patient with parathyroid storm about primary hyperparathyroidism, specifically due to parathyroid adenoma, and that's the place where we can most commonly, cure people surgically. However, parathyroid storm can also be caused by metastatic cancer or more rarely other causes, which can also lead to severe elevations of calcium. And so it is critical to ultimately and fairly quickly determine the underlying cause in order to be able to provide effective definitive treatment. The initial management steps, though, I want to emphasize, are similar regardless of what the etiology is. So when they hit the door and you know they've got a high calcium, yeah, you're going to be getting the PTH level and stuff to try to start working this up, but that should not be your first priority. Your first priority should be to resuscitate that patient and to stabilize that patient. And you first start out by significant volume resuscitation. And again, that requires generous amounts of normal saline loading and then continuing to give them fluid until you're sure that they're adequately hydrated. In some instances, as we've said, this can be augmented with loop diuretics such as Lasix, but this should not be done prior to assuring that the patient's been adequately volume repleted. You do not want to be giving these patients Lasix before you've given them adequate volume resuscitation. Otherwise, you may potentiate their risk of acute kidney injury and even that becoming chronic kidney injury. And interestingly, if you look in the literature, there's not really great data to support use of Lasix at all. It makes sense pharmacologically as the effects on sodium and calcium movements in the distal tubule provides a hypothetical rationale for utilization of Lasix, but there is very good data supporting normal saline infusion, and that has to come first. And then once you're sure that they're adequately resuscitated, if you want to throw some Lasix in there, then that's fine. And you can usually get the calcium level to come down over a day or so by 1 or 2 just with the fluid resuscitation. But perhaps more importantly is the role in fluid resuscitation in helping to mitigate or to decrease the risk of acute kidney injury. In addition then, or as the patient is being resuscitated, or once you have them resuscitated, you can also think about some pharmacologic means of getting the calcium level down. Calcitonin can be helpful here. Calcitonin is, of course, we remember from basic physiology and endocrinology, is a peptide hormone that's secreted by the thyroid parafollicular cells. It acts to inhibit osteoclastic activity and promotes renal calcium excretion. So it kind of does the opposite of PTH, both on the bone and in the kidneys. And instead of stealing calcium from the bone, like PTH does, it puts calcium back into the bone. Instead of causing you to reabsorb more calcium from the urine, it causes you to excrete more calcium in the urine. Now, during normal physiology, calcitonin really is not a significant factor in humans. It's not a significant factor in the normal human physiologic states. However, by taking calcitonin and administering it in pharmacologic doses, 4 to 8 international units per kilogram every 8 hours for a couple of days, you can get a significant clinical response and rapidly decrease the calcium by several more counts. After a couple of days, tachyphylaxis develops and you have a loss of efficacy. So calcitonin is not a good long-term pharmacologic solution to patients that have persistent hypercalcemia due to problems that we can't necessarily cure or at least readily treat, such as metastatic cancer, which we'll talk about. But it can get you some initial help in getting the calcium levels down in those patients that come in significantly obtunded and otherwise somewhat unstable from hypercalcemic crisis. Of longer term benefit pharmacologically are the bisphosphonates. These are medications. The most frequent or the most commonly used currently is zoledronic acid, but these inhibit osteoclastic function. And particularly with zoledronic acid, you have, by giving a 4 milligram IV dose, you can get calcium normalization in half of patients, so 50% of patients by 4 days, and by 10 days in 88% of patients. And this is a particularly helpful medication in patients with hypercalcemia malignancy or other high calcium states that are significantly symptomatic but not readily curable. However, in the more common cases of patients that have presented with hyperparathyroid crisis or hypercalcemia due to a parathyroid adenoma where you can cure them surgically, you may want to stay away from the bisphosphonates because they do have somewhat of a sustained effect and can therefore worsen post-procedural hypocalcemia after the patient has had their parathyroidectomy. So, you get the patient, you bring them in, you resuscitate them, you've given them some calcitonin, and you work them up, and it's, looks like it's a parathyroid adenoma. You schedule them for a parathyroidectomy a couple days later. If during that time frame you've given a bisphosphonate, then once you have the offending organ out, once you have the offending parathyroid gland out, you're going to be more likely to have severe hypocalcemia postoperatively. And so in patients that you're going to do an expeditious parathyroidectomy on, you may want to stay away from this. You also have to be careful in patients that are on the cusp of significant renal failure, as some of the bisphosphonates can potentiate renal failure. And so, very frequently, if you're going to use this type of medication, you'll probably be getting nephrology, maybe endocrinology involved. We don't have great endocrinology support in our hospital, so that's not real common, but we do have a great nephrology team. So I think that's a place where it's probably prudent to get them involved if you're going to go this far along in the medical treatment algorithm. But for me, if it's somebody that we work up expeditiously while we're resuscitating them and we're going to get their parathyroid out pretty quick, I kind of jump off after the calcitonin administration typically, unless there's a compelling reason to delay the surgery or to treat the patient further medically. Other agents which are sometimes used include monoclonal antibodies, such as denosumab, which are osteoclast receptor monoclonal antibodies, Sensipar, and other brands of Cinacalcet, which are calcium receptor stimulators, which essentially these agents mimic calcium and they confuse the calcium sensing receptor to think that more calcium is there than really it would sense otherwise, and by this means can bring the PTH stimulation and therefore the calcium levels down. Glucocorticoids can, in some instances and in some cases of refractory hypercalcemia, be helpful. These are typically reserved for patients, so all of these type medications are typically reserved for patients with cancers and other conditions in which the source of hypercalcemia cannot be reversed within short to medium time frames. So this is more, stuff for the medicine teams and the nephrology team to be concerned with. I think more pertinent to us, perhaps, in caring for patients in the ICU who may be surgical candidates, is the option for hemodialysis. Hemodialysis can be very effective at normalizing calcium over several sessions in severe cases. And it can particularly be helpful if patients are on the cusp of having cardiac arrhythmias and other acutely life-threatening complications. I mean, it's a big deal to put people on dialysis, don't get me wrong. I don't want to sound flippant about that, but if your back's to the wall and you need to treat somebody acutely with severe hypercalcemia, but you don't necessarily want to go down this prolonged medical route, or you don't want to necessarily get involved in giving some of these medications that may prevent you or may make a more difficult course post-parathyroidectomy, then getting nephrology involved and doing hemodialysis may well be a very helpful step. Okay, so as we're treating patients, again, volume repletion and then pharmacologic inhibition of bone resorption, typically for us just calcitonin. But then you do need to be concurrently determining the underlying cause so that you can ultimately bring about, hopefully, definitive treatment. This starts with obtaining a PTH level. I mean, you confirm that the calcium level is high with an ionized calcium, correction if you're dealing with total calcium and you've got a low albumin, but confirm you are indeed dealing with that. And then the first step is to get a PTH level. And then based upon what the parathyroid hormone level looks like, it's where you go in regards to the subsequent differential diagnosis. Most of the time, the PTH is going to be significantly elevated and is going to secure the diagnosis of primary hyperparathyroidism. And then it becomes a thing of, okay, well, what's causing the primary hyperparathyroidism? Most commonly, parathyroid adenoma, sometimes parathyroid hyperplasia, occasionally parathyroid cancer, occasionally other things, but usually something that we can help with surgically there. And we're going to come back to this, and spend a lot of time here because this is really where we help patients at. But let's talk about these more problematic from a differential diagnostic standpoint, at least situations where if you've got, a low PTH level, which is what physiologically you should have, right? If your calcium level is high, your PTH level should be low. So that shows you that, hey, the high calcium is not due to inappropriate PTH if the PTH is low. So then we have to look at other non-primary hyperparathyroid causes, and this goes into differential diagnosis that's somewhat broad, and these are somewhat esoteric conditions, but we'll touch upon them briefly. In other cases, you've got this kind of middle of the road where, the parathyroid level may be normal, but again, if it's in the setting of hypercalcemia, that's not really appropriate. It should be suppressed. So in instances, though, where you have a mid to upper normal or minimally elevated parathyroid hormone level, you have to worry about certainly primary hyperparathyroidism, and most of the time that's what it's going to be. But you also have to worry about some other conditions, particularly this condition of familial hypocalciuric hypercalcemia, or FHH, as we'll talk about here now. So familial hypocalciuric hypercalcemia and primary, as well as secondary and tertiary hyperparathyroidism, are all conditions in which the calcium sensing receptors have become disordered. And so to try to put things in a broader context, let's recognize again the calcium sensing receptors, which are what leads to the modulation of how much PTH is being released. And so you can have abnormalities that go both ways with this. Looking in the green down here, you can actually have some mutations of the calcium sensing receptors that cause a gain of function problem with an abnormal sensitivity to calcium, leading to hypoparathyroidism and low calcium pathophysiology, so hypocalcemia. And this is examples of these, such as Bartter syndrome, are listed here or in this up-to-date table, which we have highlighted in the green here. These are for the most part only of peripheral interest to us as surgeons, perhaps if somebody's dealing with it that we're caring for in the ICU otherwise, but there's not really a surgical treatment for that, so it's not as directly involving us. Inactivating mutations, meanwhile, here in the red and the orange, decrease the calcium sensing receptor sensitivity to calcium and thereby cause excessive PTH release and hypercalcemia. And there's kind of two basic flavors of this. These include when the calcium sensing receptors that are deranged are limited to the parathyroid gland. So it's just in the parathyroids only that you have the abnormal receptors. And that's basically what we deal with most of the time, primary hyperparathyroidism. Also in the setting of renal failure, secondary and tertiary hyperparathyroidism, which is not really part of this discussion, but is important to recognize. But these are pathophysiologies which are often benefited from surgery, particularly primary and tertiary hyperparathyroidism. You also have to recognize, though, from a differential diagnostic standpoint, the potential for these other disease processes here in the red. These are generalized disorders of all calcium sensing receptor tissues, not just because there's calcium sensing receptor tissues in other tissues other than the parathyroid gland. And when you have that occur, you can't typically cure it by just taking the parathyroid gland or glands out. So these are conditions which are not benefited by parathyroidectomy here. And the most common of these is the FHH, or familial hypocalciuric hypercalcemia. And it can mimic in some ways the lab test that you would see with hyperparathyroidism, and therefore it's important to distinguish, because if you take the patient and take them to the operating room, you're not going to help them in the setting of FHH. So let's look just for a couple minutes here at familial hypocalciuric hypercalcemia. This is an autosomal defect in the calcium sensing receptor genes, which produces typically an asymptomatic mild to moderate hypercalcemia concurrent with an inappropriately normal or high PTH level. So kind of the same pattern you would expect to see with hyperparathyroidism, just usually more on the milder side. The key is that the urinary calcium level is low in these patients. And that's important. Now, it becomes a little bit counterintuitive, because if you think about it, we've said, okay, what happens when you have too much PTH that's around? Well, one of the things it does is it causes more absorption of calcium from the urine. So would you not then have low urinary calcium in the setting of primary hyperparathyroidism because of that effect of PTH? And the reality is no, because you have such a high calcium level that occurs, you still spill much more calcium into the urine than typical. So when you have primary hyperparathyroidism, you are going to have high urinary calciums. And that is a means of distinguishing it, which can be benefited from surgery, from this condition of familial hypocalciuric hypercalcemia, where the urinary concentration is low and these patients won't be helped. And so, since there's no benefit from parathyroidectomy in these cases, you need to check, particularly if it's just a mildly elevated PTH level. You need to rule out FHH so that you don't get confused on the differential diagnosis. So basically, one of the things you're going to get if you see that the PTH is elevated, another test you're going to do is just a 24-hour urinary calcium. And if it's less than 200, then you have to worry about FHH, and you need to do more testing, maybe get endocrinology or nephrology involved to help you tease out that differential diagnosis. On the other hand, if your urinary calcium's 3, 4, 500, and the PTH is high, you've pretty much secured the diagnosis of primary hyperparathyroidism. In instances in which it's kind of a little bit borderline and you're not sure, let's say maybe the urinary calcium is like 205 or 198 or something, you can actually calculate a fractional excretion of calcium just the same way we calculate a FeNA, but instead of plugging sodium in, you plug calcium in after getting urinary and serum lights. And if the fractional excretion of calcium is less than 0.01, that's consistent with FHH. If it's greater than 0.02, that's more consistent with primary hyperparathyroidism. Now, I do want to clarify, there are other conditions in which you can see a high serum calcium, but also a low urine calcium. So, in other words, other things which can mimic FHH. Vitamin D deficiency, some cases of kidney insufficiency, thiazide diuretics, higher doses of lithium can all cause this. But in those instances, your PTH level is not going to be elevated. So that helps differentiate those. So what's the role of urinary calcium, 24-hour urinary calcium? Primarily to rule out FHH and help you secure the diagnosis of primary hyperparathyroidism, which can be helped with surgery. Okay, let's look now for just a couple minutes at hypercalcemia occurring with a low PTH level. And by low, we're usually talking less than 20 picograms per milliliter. This is consistent with a number of non-PTH mediated etiologies and should lead to further testing with PTHRP levels, vitamin D levels, and other evaluations. This is typically going to be the purview of the medicine team, the nephrologist, the endocrinologist, and less likely to involve us, with some exceptions, particularly related to cancer, because the most significant of these is hypercalcemia of malignancy. And so I think since we take care of a number of patients, particularly breast cancer patients, which can manifest this, I do think it's important that we have some working knowledge of this, but these are not conditions that can typically be cured with surgical intervention. There are some exceptions to that, and we'll touch upon those briefly. But let's look here just for a couple minutes at the diagnostic evaluation of hypercalcemic patients with low PTH levels. And again, the most significant of these is hypercalcemia of malignancy. So let's start there. Hypercalcemia occurs in up to 25% of cancer patients and tends to be associated with advanced disease and a poor overall prognosis. The most common cancers which are implicated in hypercalcemia are breast cancer, lung cancer, renal cancer, and multiple myeloma. Parathyroid cancer as well, although that's a little bit of a different situation in that there's actually a component of primary hyperparathyroidism in that case as well. So we're going to look at that as a kind of a special and unique entity and talk about that separately. But for right now, talking about breast cancer, lung cancers, renal cancers, multiple myelomas, other cancers that can present with a non-PTH mechanism for hypercalcemia. The pathophysiology in these instances involves two basic mechanisms. Over here in the orange, the humoral hypercalcemia of malignancy mechanism, and over here in the green, the local osteolytic hypercalcemia. Let's look at the humoral etiology first. This is where tumor, whatever the tumor is, secretes systemic factors which act on the bone, gut, and kidney to disrupt normal calcium homeostasis. The most common of these is PTHrP, which stands for parathyroid hormone related peptide, so a similar peptide but different from PTH. Also, though, vitamin D can be secreted by some tumors. There's actually a few instances, most commonly seen with ovarian or neuroendocrine tumors, where PTH itself is produced ectopically and has the same effect. And so there you have a unique situation where you've got both a humoral hypercalcemia of malignancy, but also a hyperparathyroid mechanism for the hypercalcemia. And the same goes for patients that have the unusual condition of a parathyroid cancer. But breast cancers, lung cancers, renal cell cancers, multiple myelomas, etc., can at times release PTHrP or other cytokines which can have PTH-like effects on the bone, gut, and kidney, and therefore cause hypercalcemia. In other instances, you have the local osteolytic hypercalcemic mechanism occurring. This is where tumor cells in the bone produce cytokines which act locally, not systemically now, but locally, to increase osteoclastic bone resorption and or suppress osteoblastic function. So you have metastasis to the bone, which there in the bone is increasing bone reabsorption and or decreasing new bone breakdown and bone maintenance. Here's a table from an excellent review published in the April 14th, specifically 2022 New England Journal of Medicine. And here is summarized the two basic mechanisms of hypercalcemia of malignancy, along with common causes, with humoral here in the orange, the local osteolytic in the green. It's kind of a lot to go over in the form of a podcast, but it will submit this so that you can have it for your review on the site with the PowerPoint, because I think it's pretty helpful to gain understanding of what these cancers are and how they can bring about hypercalcemia. In these cases, these are examples of cases in which long-term medical management of hypercalcemia with bisphosphonates, calcium sensing receptor binders, and or glucocorticoids is often needed, while the underlying malignancy is addressed typically by the medical oncology team. So it's less common that we as surgeons, probably fairly uncommon that we as surgeons are going to be too involved in these patients' care. Again, one notable example though would be the neuroendocrine tumors, which can occasionally produce, for example, parathyroid hormone. And so, by resecting a neuroendocrine tumor or debulking a neuroendocrine tumor there, that might be an unusual set of circumstances where you can actually help a patient with a hypercalcemia of malignancy surgically. Also necessary to know about, but much less likely to present with severe hypercalcemia are a number of other non-PTH mediated causes, including granulomatous diseases. And there's just this whole list here, which I've reproduced from the 2022 up-to-date article on this. But you've got granulomatous diseases, vitamin A toxicity, a number of endocrine abnormalities. Hypercalcemia can be a manifestation, it turns out, of some cases of hyperthyroidism or of growth hormone excess. Some pheochromocytomas will also elicit and cause hypercalcemia. And on the opposite end of the spectrum, adrenal insufficiency can as well. So there's a number of endocrine causes. Also occasionally encountered is this interesting condition of milk alkali syndrome. These are conditions used to be more commonly seen before we had good proton pump inhibitors and H2 blockers and things to treat ulcers, where people that had ulcers would consume high amounts of calcium containing antacids and large quantities of milk to try to palliate their symptoms. And with that, you can get hypercalcemia occurring as a result. So the milk alkali syndrome is a consequence of too high a calcium and alkali intake. Can also sometimes be seen in people that are on both calcium and vitamin D supplementation if a thiazide diuretic is added to it, because thiazide diuretics promote calcium reabsorption. And thiazides in and of themselves can at times cause hypercalcemia, just as they can also cause hyponatremia. The milk alkali syndrome can sometimes present with severe hypercalcemia. If you have patients that are coming in, this is one thing to think about if the PTH isn't elevated, is a variant of milk alkali syndrome. This is actually a case study from back in 2016 in one of the specifically August 11th New England Journal of Medicine. And this was a patient who presented with AKI mental status changes in the calcium of 15 due to a combination of antacids, milk, calcium and vitamin D supplements, as well as hydrochlorothiazides and NSAIDs. And so, they had to do significant work diagnostically in this patient as well as therapeutically, and then ultimately figured out that they just needed to stop some of these exposures and things he was taking in. So for the most part, when you see somebody that comes in that has very high calcium levels, you're thinking typically hyperparathyroidism or hypercalcemia of malignancy in the majority of instances. But in some other instances, one has to put their thinking cap on a bit and check for other things like the patient's medical history to see, are they on a thiazide, maybe taking too many antacids, which contain calcium? Are they taking excessive amounts of vitamin A? What are their TSH levels? What are their cortisol levels look like? To look for some of these more rare etiologies. But again, it's less common that these cause severe cases of hypercalcemia. Okay, so having reviewed all of that, we will finally get to turn our attention to the most common cause and the scenario in which we as surgeons are most able to be helpful, that of hypercalcemia due to primary hyperparathyroidism, most commonly due to parathyroid adenomas. And we'll pick up with that in the next module.